Idiopathic Pulmonary Fibrosis, or IPF, is a condition which results in progressive scarring of the lungs, which eventually leading to the patients not able to breathe, and they die from suffocation. It's idiopathic, meaning that it is not associated with any other known causes. So as the IPF progresses, the lung becomes stiff. The patient felt very restricted. They could no longer actually breathe adequately. They frequently compensate by coughing a lot to try to actually expand the lung. And basically, they could no longer walk, they can no longer function. And they would then eventually go on requiring oxygen. IPF in Canada, we estimate there may be about 9,000 patients. Each year, roughly 1/3 of them passed away from IPF. So basically, if you compare IPF survival, it's almost as bad as some of the worst cancers out there, like lung cancer, pancreatic cancer. And unlike the cancer arena, whereby there have been some improvement in certain subset of cancer, we have been able to offer not only cure, but also significant sort of control of cancer. IPF, up until now, we have had no proven therapy for. Finally, now we have a drug that has been approved in Canada for the treatment of this condition. It is not known to cure this condition, but it's been shown to actually slow down the progression of the disease. It's been a long time coming, and I've been in this business for 13 years looking for a cure or treatment for IPF patients. I've been involved with 7 or 8 clinical trials over that span of time. And so far, this is the only one that actually has met the benchmark of showing that it actually protects the lung and slow down the decline of IPF, and finally offer the patient hope and a chance to actually help to manage the condition. The name of the new drug is called pirfenidone, and which is also known as Espreet, which is the trade name. It is a pill. The way how it works is that it is partially what we call an anti-inflammatory. That means it cuts down the inflammation in the lungs. But most importantly, it is an anti-fibrosis agent. So what Espreet or pirfenidone has been shown in at least 3 large-scale clinical trial studies is that over a period of at least 12 months, and actually in one study beyond 12 months, that it actually slowed down the decline in the lung function, which is one of the ways we measure how the disease is progressing in IPF patients. We get them to breathe to blow into a breathing machine, and we quantify the size of the lung. We call that vital capacity. And what the drug has been shown in these clinical trials is that over that period of 12 to 18 months, compared to patients who did not receive the drug, it actually slowed down the loss of lung function. So in other words, it protects the lungs. And some other what we call secondary endpoints, i.e. patients' general well-being, their ability to walk, their ability to function, have all improved as well. And then there's also a trend to actually, at the end of 18 months or longer, of lower mortality. Espreet is approved for patients with mild to moderate IPF. Mild to moderate IPF means that these are not patients with very advanced IPF that we expect them to die in the next 12 months. Most of these patients have been diagnosed within the last 6 months up to about 3 years or so, and during that period of time has shown to us that the disease has not gotten better. If anything, they have been steadily getting worse. It is taken by mouth 3 times a day, and is associated with generally well-tolerated minimal side effects. The approval of Espreet means that now I have an option of a proven effective therapy that can slow down the progression of disease. So I think this is potentially a sort of a game changer for the IPF patient.
Idiopathic Pulmonary Fibrosis, or IPF, is a progressive and fatal form of chronic interstitial lung disease that eventually leads to the destruction of lung architecture and ultimately respiratory failure. The exact mechanisms by which IPF occurs remain unknown. Early hypotheses suggested that this devastating disease was caused by chronic inflammation that led to fibrosis. However, an increasingly favored hypothesis suggests that a still unidentified stimulus or stimuli produces repeated injury or insult to the alveolar epithelium, followed by an abnormal repair response that leads to unremitting fibrosis. Let's take a closer look. Despite the unknown etiology of IPF, several potential associated factors have been identified and include genetic predisposition, smoking, environmental dust exposure, gastroesophageal reflux disease, oxidants, and viral infections. The specific sequence by which the pathogenic mechanisms of IPF occur remain poorly understood, but are currently believed to begin with repeated injury to either the function or structure of alveolar epithelial cells. Once injured, the activated epithelial cells stimulate the release of several profibrotic and inflammatory mediators, including transforming growth factor beta and tumor necrosis factor alpha. TNF-alpha and other cytokines mediate recruitment of inflammatory cells, while TGF-beta and other growth factors stimulate the migration and proliferation of fibroblasts, which begin deposition of collagen matrix to initiate the repair process. Growth factors are also believed to play a role in the emergence of myofibroblasts from resident cells. Over time, these cells organize into clusters known as fibroblastic foci, where they continue to deposit extracellular matrix. The healing process becomes uncontrolled and dysregulated as matrix accumulates and the fibrosis becomes established. The dynamic balance between matrix synthesis, degradation, and resorption may become imbalanced, further contributing to the fibrotic process. The injured epithelium is unable to restore itself and becomes vulnerable to apoptosis or programmed cell death. In addition, the now exposed underlying basement membrane becomes disrupted, allowing fibroblasts to infiltrate the alveolar space. Conversely, fibroblasts and myofibroblasts fail to undergo apoptosis, resulting in continuous alveolar invasion and deposition of matrix, contributing to further destruction of normal lung architecture. The disease becomes more extensive due to repeated injury, each at different stages of development throughout the lung. This explains the temporal heterogeneous pattern interspersed with healthy lung tissue and the gradually increasing accumulation of matrix, unremitting fibrosis, fibroblastic foci, and honeycomb cysts that are the hallmark features of idiopathic pulmonary fibrosis. However, as our understanding of the underlying mechanisms of IPF evolves, from that of a disease resulting from chronic inflammation to that of one due to recurrent epithelial cell injury and aberrant fibrotic processes, our treatment approaches are evolving too.